Welcome to our Community Connect program. My name is Bob Twillman. I'm the Deputy Executive Director and Director of Policy and Advocacy for the American Academy of Pain Management. My work is really focused on the oversight of both federal and state policy related to pain management and advocating for policy that supports good, complete, integrative care in managing pain. In addition to that, I serve as the chair of the prescription monitoring program for the state of Kansas, which gives me some insight on how those programs work and frankly makes me a big cheerleader for those programs. So with that, let me get into introducing the rest of our panel here. I'm happy to introduce first in a near chair here, Professor David Brushwood. David is a professor of pharmaceutical outcomes and policy at the University of Florida College of Pharmacy. David has practiced the professions of both pharmacy and law before entering academia. His research focuses in the area of regulating for outcomes, medication error prevention, and pain management policy. In the center chair is Dr. Bill McCarberg. Bill is the founder of the Chronic Pain Management Program at Kaiser Permanente. He's a prolific author on pain management, has numerous leadership roles in Pain Medicine Society, and serves on the board of clinical directors of the National Pain Foundation. Bill is also president of the elect of the American Academy of Pain Medicine. And finally, we have Dr. John Coleman. John is the president of Prescription Drug Research Center. He brings to our discussions 30 years of service at the DEA, where his assignments included Assistant Administrator for Operations, the highest career position in the agency. He's co-authored numerous articles on the regulation of controlled substances and the abuse of prescription drugs. And last but not least, I'd like to thank our sponsors, Janssen Pharmaceuticals and the American Academy of Pain Management, for hosting this meeting and bringing us together so we can talk about some of the issues that we have related to opioid prescribing and monitoring and dispensing, and talk about ways we can do the best for all of us, for our patients in treating their pain. So let's start this off with a potential real-life scenario that we might face every day in regular practice. You may hear some things in this scenario that sound awfully familiar, but let me set the stage for us. Our patient is a 28-year-old woman with a history of low back pain. She's taking methocarbamol, 750 milligrams TID, carisoprodol, 350 milligrams TID, escitalopram, 20 milligrams Q-day, tramadol, 50 milligrams 1 to 2 TID, averaging about 217 milligrams per day, alprazolam, 2 milligrams TID, all of which are prescribed by 3 different doctors. The patient on this particular day presents at the pharmacy with a new prescription for a fentanyl patch, 75 micrograms, Q72 hours, PRN. The pharmacist is aware of the patient's drug information because he's filling all of these prescriptions, but he doesn't know anything else about the patient's history. So the pharmacist, being in a quandary about what to do with this new prescription, calls the doctor's office and is put on hold for 16 minutes. 16 minutes later, a rushed physician answers the phone.
Hello, this is Dr. McCarberg.
Hey, doctor, this is Dave. I'm a pharmacist at Community Care Pharmacy. I have a question about Mrs. Smith. There's a problem with the script that you wrote for her.
Hey, listen, I'm busy. Who is this again?
I just wanted to point out, doctor, this patient appears to be opioid naive. She really shouldn't be given fentanyl at all, and certainly not at this dose.
You guys at Community Care Pharmacy are constantly calling me about this stuff. Listen, I'm an experienced pain management physician. Can't you see I'm busy? I've got to go.
But doctor, I can't fill this, I can't give her medicine, I just can't.
Sound familiar to anybody? We see and get reports of these kinds of interactions, and I think what we want to do is talk about ways that we can improve the process so that as pharmacists and as prescribers, we collaborate better in better service of not only ourselves and our professions, but also our patients, especially our patients, and ensuring that they get safe and effective care for their pain. What we've done is we've brought together pharmacists and prescribers to have that kind of a discussion. Because what we found is that many times pharmacists don't understand what's going on in the physician's office or the prescriber's office. They don't understand the pressures that prescribers are under. And prescribers don't understand the pressures that pharmacists are under. And so when our experience has been that when we've been able to explain a little bit about what's going on, the light bulb comes on and people figure out ways to work together better, and everybody's a lot happier in the end. Clearly, the situation that we're in today is a complex and challenging situation. We're faced with two major public health crises, the crisis of uncontrolled chronic pain and the crisis of prescription drug abuse. We have to find ways to address both of those at the same time, and that becomes a real challenge for us. Because for some people with chronic pain, the best treatment is prescribing an opioid. On the other hand, if we prescribe too many opioids or prescribe them too often, then we wind up in a situation where there's an excess supply that sometimes leaks out into the illegal distribution channels, and people wind up misusing them, abusing them, and in some cases overdosing and dying. So we have a real challenge and a real conundrum about how we can manage to address both of these things at the same time. And part of what we want to talk about is how a greater collaboration between prescribers and pharmacists can help us in accomplishing that challenging and difficult balancing task. So what we have to do is to begin to find ways to address this problem and to also address the very significant problem that we have with prescription drug abuse. So let's start with a question for Dr. McCarberg. Bill, tell us a little bit about what's your perspective on the magnitude of the problem that we encounter with uncontrolled pain?
I am a primary care doctor, so what I typically do in my office is coughs and colds and hypertension and diabetes. I have this subspecialty of chronic pain, so I treat a lot of chronic pain patients. If you look at that 110 million Americans that have chronic pain, most of those are being seen first by the primary care provider. They're being managed long-term by the primary care provider, and often either a specialist isn't available or the specialist is somebody that may just do injections and not really manage it beyond an injection. They're going to be managed long-term with a provider that's not very good at doing that management. They weren't trained to do it. They don't have the time to do it. And what they typically do would be kind of like what you see in this patient. So I think this interaction that happens between the pharmacist and the primary care doctor who's really doing a lot of this pain management is so vital, because in this particular instance it wasn't correct, and the pharmacist would be the person that could catch that error and take it back to the provider if the two were communicating, but they're not communicating. So it's in primary care, Bob. We're doing it, but we're not doing a good job for a whole variety of reasons. Not that we don't want to do a good job. We want to help the patients. We're just not doing it very well right now.
Right. So that talks a little bit about the issue with managing chronic pain in the primary care setting. What about the concomitant problem of managing prescription drug abuse? How does that come into play in the primary care setting?
Well, it's seen as very black and white in our setting, is that if there's an abuse situation, we're just going to drop out and not prescribe ever again. And that's happened across the United States in primary care. I work in a federally qualified clinic, a healthcare center, which is an indigent care center, and one of our clinics of 5 providers, so that's 3 NPs and 2 doctors, have decided they won't give anything more than hydrocodone for chronic pain. I ask you, is that the wise thing to do? They won't do anything more than that, and after 3 months they won't prescribe at all, so the patient has to seek other care providers. Now, why is that a good option? But that's what they've decided to do, and I think across the country we're hearing reports about that the provider becomes confused, they're not sure what to do, they just drop out. So it's a very black and white phenomenon for them.
Right. So David, as a pharmacist, what do you see going on in pharmacies now around these issues?
Well, I'm happy to hear Bill describe the problems that prescribers face, because misery loves company to a certain degree. Pharmacy has a lot of challenges as well. The main challenge in pharmacy is to meet this responsibility to assure that people who need their medicine get it, but people who don't need medicine don't get it. That's really easy to say, very, very difficult to implement. And there are just a number of resources that we need and don't really have. One of them is a valid, sensible approach to screening prescriptions and to stratifying the risk of each prescription, so that we don't call prescribers and occupy their time with patients who are really pretty easy and aren't problematic, but that we do contact prescribers and work out with them a way to get medicine to somebody who has some sort of problematic situation. You know, we talk about red flags, and there's this long list of red flags. What does this mean? The patient lives 100 miles away from the pharmacy. Okay, that's a red flag, admit it, but what do you do about that? There can be some explanations for it. The patient has lost medication twice within the last year. Okay, that's a red flag, certainly, but what am I supposed to do? So we need to develop some standards. And another challenge for pharmacy is getting the product, getting the inventory, getting the wholesalers, the distributors to provide enough product. I think both of these challenges, screening prescriptions adequately and getting enough product, can't be resolved at the pharmacy level without prescriber collaboration. There has to be a collaboration between prescribers and pharmacists to address both of these.
And this is a good example of the case that we talked about, because this patient may actually need medication. It's not that she's overusing or overdoing. She's not an addict by the details that we've given here, right? But it's an inappropriate dose, so it's incumbent upon the pharmacist to take all of that into account and communicate with us, as you tried to do and I wouldn't listen to.
The role you played was a very unsympathetic role, but I could have done a better job of establishing a pre-existing relationship with you and not had to explain to you who I am when I call with a problem. It's not a good time to establish a good relationship when there's a crisis happening.
So, Bill, when you get these kinds of calls in your practice, what goes through your mind, and what's your reaction when you get a call from a pharmacy?
Typically, that call is so important to me, but I'm hassled by it. I'm annoyed by it because it's coming at a time I'm busy. I don't want to take the call, have somebody else handle it. Just as I did in this case. I blew him off thinking, I'm the doctor, I know about this patient. And the pharmacist is trying their best to say, it's opioid naive, 75 micrograms. That's not good. So I always am reassured when I talk to the pharmacist. I always take the call. The more I know the pharmacist, the more relationship I have with that pharmacist, the more likely this interaction is going to be a good interaction. Because when Sally calls me from my local pharmacy, I know exactly who Sally is. She never calls unless it's really important, and I always pick up the phone right then. I don't care how busy I am. It's an emergency. I need to pick it up. And I think that's typical with these pharmacy calls.
Yeah. So, well, David, what about being on the other side of that phone call from the pharmacy?
It's a tough position to be in because pharmacy holds the trump card here. Pharmacy can decide to not fill the prescription. And that's not an easy decision or a satisfactory decision. It's unsatisfactory because what I'd like to do is play a better card than play the trump card. We probably together, if we had been able to have a discussion, we could have probably figured out a better way to meet this patient's needs.
One of the things that we have to do today, because we're confronting both of these problems, is we have to, I think, really do a good job of a risk screening and risk stratification up front with the patient. So, Bill, what kinds of things do you do in your practice to help you stratify risk?
So I get patients by referral, and I always risk stratify them using a tool. It's called the Opioid Risk Tool. It's a short form I can pull up online. I can print it out, have it in the chart, and that tells me whether the patient's at a medium, low, or high risk. And that doesn't mean I don't prescribe for the patient, but it means I change how I prescribe. I may give a smaller amount of medication. I may do more often urine drug testing on the patient. So I stratify the risk based upon when the patient comes in, how well I know them. If you look at people that have been on drug for 3 months, typically they started with an acute problem. The primary care provider doesn't think this is ever going to last long.
Yeah, so, and pharmacies also do some risk stratification.
Yeah, pharmacies are starting to do risk stratification of a different kind, and it synergizes with the risk stratification that the physicians do. I have a program called Vigil, V-I-G-I-L, and you can just Google Vigil, V-I-G-I-L, and Brushwood, my last name, find out more about how these factors, they are objective factors. The patient either lives in the same 3-digit zip code or does not as the address of the pharmacy. The prescriber either is or is not within the same 3-digit zip code. That's a negative factor. There's some positive factors, what I sometimes call green flags. For example, a clean or a non-problematic PDMP, Prescription Drug Monitoring Program report. That's a green flag, and you balance them. There's a systematic way to do that. And then contact the prescriber if necessary. Now, if on balance, this is a low-risk patient, no need to contact the prescriber to raise all sorts of concerns that don't exist. On the other hand, if it's a high-risk patient or high-risk prescription, from the pharmacy perspective, in order to fill it, you're going to have some collaboration with the prescriber. And if the prescriber doesn't want to collaborate in that way, you have no recourse. There's no alternative but to refuse to fill it.
So both of you are doing risk stratification, but it's on different factors. And so to what extent can combining those two pieces of information be helpful?
I think it's huge. I mean, we can find out from the prescriber how they have risk stratified the patient. They can find out from us how we have done it. And 1 + 1 = 3, in my view, when you do it that way. Working together, which is not easy, can help solve this problem that we mutually face.
So the two of you have agreed that this kind of communication back and forth is vital. It's really very important and leads to better outcomes for everyone.
Right. I mean, and what we've heard from pharmacists is that they actually make an appointment, go to their nearby prescribers' offices, knock on the door and say, I'm here to talk with you for 30 minutes or so, and they end up actually meeting each other for the first time. They've been colleagues for the last 3 years and haven't ever met each other. So that's a necessary, I think, first step.
You know, and it's difficult now because there are so many pharmacies. So if you thought all of the prescribers that come through your pharmacies, you should sit down and do a 30-minute with, you can't because there's too many. When I worked with Kaiser, I knew all of my pharmacists because it was one pharmacy. We went to lunch together. I knew them very well. They knew what I was doing. They knew my practice style. But now I'm in this community clinic, and we must have 100 pharmacies out there. But there are a few number that I use a lot. And if they came in, and I know them pretty well, I know them by first name when they call and talk to me, getting a relationship with that pharmacist I think is important.
So we've talked a little bit about clinical care and some of the things we need to do in a clinical setting. Let's shift gears just a little bit and talk about the regulatory environment.
It's very interesting listening to my colleagues describe the tension that exists between the pharmacy community and the medical community. That's not something new. That's actually predates the first statute, which was passed actually 100 years ago. It was 1914 Harrison Narcotic Act. We go back 100 years to this issue, but basically the reason I bring that up is that essentially set up the sort of dual nature of the prescribing issue, where the prescriber prescribes the drug and the dispensing pharmacist dispenses the drug. So that was actually written into the law. In the Controlled Substances Act in 1970, it was codified where it says specifically in the regulation that in order for a prescription to be valid, it must be issued by an individual practitioner for a legitimate medical purpose in the usual course of business. Now those elements are somewhat vague, but they've been well defined actually in case law. But the regulation goes on to say that the primary responsibility for the validity of that prescription rests with the prescriber. However, there's a corresponding responsibility on the part of the pharmacist that fills the prescription. Now, that corresponding responsibility is not defined in the law, and as David mentioned, it probably would be a good idea to have a little bit more substance behind the definitions here. But bottom line is that in case law, it has been described as red flags, essentially, and David mentioned a couple of those red flags. It's a question of due diligence, and the law recognizes that. It's a requirement if that pharmacist feels that there's any doubt as to the validity of that prescription, he or she cannot fill it unless they resolve that question. And the quickest and best way to resolve it is to call back to the prescribing authority. So you get a call from a pharmacist, that's an official call. That's the way the DEA would look at it, is an official call was made to verify this prescription. And the prescription was then verified and the drugs were dispensed. Or the prescription was not verified and the drugs were not dispensed. And so the DEA is very cautious about maintaining that relationship, but it has to be a collaborative relationship. I think the preceding discussion here essentially established the need for that collaborative relationship, because it cannot be one track or one person making all the decisions. It has to be a dual situation whenever there's a question. Now, there's not, the vast majority of prescriptions, there may not be any questions whatsoever, no red flags raised, and the pharmacist just goes ahead and fills the prescription. On the other hand, if there's a pattern of prescriptions that are coming out of a particular pharmacy and they're troublesome or difficult, whatever, traced back to improper prescribing practices, that could be problematic. And again, it's a question of due diligence on the part of the pharmacist to make that call or check the PDMP, for example, to resolve. As David says, if you get a clean report, that's a green flag.
And I want to ask John to go into a little bit of detail about it, is the Prescription Drug Monitoring Program, the PDMP.
Yeah.
So tell us a little bit about those programs.
Yeah, the Prescription Drug Monitoring Program it's not new. It was developed in the 40s in California and New York, but back in those days it was all pencil and paper, and the records never really got collated or archived to any great extent. It wasn't really until the modern technology and information exchange and so forth that they were able to create these systems that actually are very responsive. And in about 49 states actually have passed legislation allowing for prescription drug monitoring programs, and there's probably about 47, 48 up running right now. These programs are very valuable because they do collect the information from the individual pharmacy when the drugs are dispensed.
We're getting close to the end of our time. Let's talk a little bit about some of the solutions and some of the ideas about ways that we can facilitate this kind of easy cooperation between prescribers and pharmacists.
Dave talked about the fact that you can make a lunch hour conversation with the provider. We always have these conversations, and once you have that interaction, that personal association, it's much easier to pick up the phone.
You know, and we've talked about pharmacists coming into the medical practice to introduce themselves. What about going the other direction too? You know, a prescriber who's out for lunch or on the way home, just stop in at one of the nearby pharmacies, which undoubtedly gets a lot of prescription business, and just introduce yourself and say hi, and you know, this is who I am.
Just want to know who I am, and yeah, absolutely.
And I think it's just human nature that it's a lot easier to be nice, frankly, and to be cooperative with somebody who you can put a face on. And it's not just that scribble on the bottom line that you can't read, you know. But so I think it really does make a difference for people to introduce themselves that way. So we've talked a lot today about some ways in which we can facilitate that cooperation, that collaborative work, all in the interest of making life easier for the prescriber, making life easier for the pharmacist, but especially making life better for the patient, and ensuring that the patient gets safe and effective care for their pain. So lots of ideas. Hopefully they're ideas that you can take back with you to your practices and begin to implement. Thank you very much for your attention. You've been a great audience. We appreciate it. Thank you.